everyone, good afternoon. I would like to present my PhD, which is about the investigating of radioembolization as an option in the treatment of liver tumors. My name is Petra. I'm a PhD student and a radiology clinician at the Medical Imaging Center. My vision is that we will cure, not treat. And I would like to achieve that by determining the efficacy and the safety of the isotopes used for radioembolization. I have two ongoing projects right now. My first project is about investigating the safety and the efficacy of holmium radioembolization in patients with liver tumors. This is going to be a systematic review and meta-analysis. So liver tumors are a global health problem. However, only 30 to 50% of these tumors are suitable for definitive therapies. Therefore, there is a need for local regional treatments. Local regional treatment options are ablation, transarterial chemoembolization, and transarterial radioembolization. And according to guidelines, there are scenarios when radioembolization is the best option because it can be potentially curative. In the clinical practice, we use two isotopes, yttrium and holmium. As you can see in this table, these isotopes have different characteristics. Holmium is a newer isotope and has some advantageous properties that yttrium does not have. Holmium is suitable for SPECT and MRI imaging. Here in this picture you can see how it looks like. And this is good for us because we can calculate the tumor response and we can evaluate dosimetry and so on. Also, holmium can be used as a scout and has a superior predictive value for intrahepatic distribution and dosimetry. So in the literature, we have a lot of evidence about the safety and the efficacy of yttrium for the radioembolization of liver tumors. However, for the evidence on using holmium for this purpose needs to be more comprehensive. Therefore, our aim is to define the safety and the efficacy of holmium radioembolization. Our clinical question is that in patients with liver tumors, is transarterial radioembolization using holmium isotope a safe and effective way of transarterial treatments? Our outcomes are tumor response, overall survival, toxicity, and quality of life. We conducted our systematic search in 5 databases with the following search key. And in the end, we've got 17 eligible articles and 6 ongoing trials. We finished the analysis of the main outcome, which is the tumor response at 3 months. And here I would like to introduce this outcome a little bit. So radioembolization do not primarily has its therapeutic effect by embolizing the vessels of a tumor and cutting off the blood supply, therefore inducing an ischemia, but by delivering beta-emitting radioactive isotopes, which causes DNA fragmentation and tumor cell death. So this process can last for months. And therefore, the tumor size won't necessarily reduce because we don't embolize the vessels of the tumor. Here you can see that RECIST measures the whole tumor size, including the living and the dead necrotic part as well. But in contrast, modified RECIST measures only the living part of the tumor. Therefore, modified RECIST is more relevant to us in evaluating the efficacy of radioembolization. We would like to express tumor response in terms of disease control rate. And disease control rate refers to how successful we were in preventing the living tumor from growing. And that's why modified RECIST is more relevant to us, because it only measures the living part of the tumor. Here you can see my results. My results are in proportions. Proportions refer to the ratio of the patients whose tumors were controlled by holmium therapy. As you can see, holmium therapy was quite effective in controlling the tumors of many patients. So for both systems, we have 5 articles each, covering nearly 100 patients in both cases, and these are all mixed observational trials. So as you can see, in RECIST studies, the between-study heterogeneity is quite high, whereas in modified RECIST studies, the I-squared test could not give us reliable results, probably because of the small number of studies included. However, we expect that the heterogeneity in modified RECIST studies would be similarly high as well. And the reason for heterogeneity could be the different patients, the different centers, but ultimately the underlying reason is that these are observational studies. So you can see that according to RECIST, nearly half of the patients had their tumors under control. But according to modified RECIST, more than 90% of the patients had their disease under control. Since we know that modified RECIST is more sensitive, it clearly indicates that holmium therapy is effective. The difference between the two systems are also reflected in the mathematical results. If you look at the wide confidence interval associated with RECIST, you can see that this 54% is not really a reliable result. However, the confidence interval of the modified RECIST is quite high and narrower than the RECIST one. So with these results, we can suggest that holmium treatment works for the actually clinically relevant outcome, which is the rate of the tumors that are successfully prevented from growing. Yes. And we did the risk of bias assessment with minor, which is recommended for one-arm studies, and these are one-arm studies. The strengths of our study is that these are clearly answers the research question with sound methodology, and it informs both future practice and research. The limitations are that these were only observational studies that we included, and the older publications are less relevant than the newer ones. So the implication for clinical practice is that we should use modified RECIST system because it's more sensitive, and we can use holmium because it is effective. The implication for research is that we open the door for targeted interventional trial designs, which I will show in my second project, and that the further clinical studies are needed to overcome the potential limitations arising from the risk of bias. Here you can see the progress of mine, where I am now. Okay, so my second project is about comparing the use of holmium and yttrium isotope in transarterial radioembolization for the treatment of liver tumors. This is going to be a protocol of a randomized controlled trial. As I mentioned before, local regional treatment options include transarterial radioembolization, which has 2 isotopes, but these isotopes have different characteristics. And we don't know if these isotopes have the same effect in different tumor types and in different populations. So we would like to determine if holmium has different efficacy and safety than yttrium. Our clinical question is that is radioembolization using holmium isotopes at least safe and effective as radioembolization using yttrium isotopes in the treatment of hepatocellular carcinoma patients? We would like to measure the tumor response, the survival data, and the toxicity as well. And our clinical implication would be that the efficacy of yttrium and holmium might be different in different tumor types and populations, and we could explore that. Here you can see the eligibility criteria, my inclusion criteria, and the exclusion criteria for the study. Here you can see the intervention, the 2 arms. Arm A is going to be TARE using yttrium isotopes, and Arm B is going to be TARE using holmium isotopes. These are the outcomes that we would like to measure. So the primary outcome would be, yes, I'm trying to, okay. So the primary outcome is tumor response rate according to modified RECIST because it's more sensitive at the given time points, and the secondary outcome would be dose response relationship, survival data, toxicity data, and quality of life. So to sum up, I have 2 studies ongoing, and I would like to submit them until May and August 2024. I would like to finish my presentation with a quote: "Man can learn nothing except by going from the known to the unknown." Thank you.
Thank you very much, Petra, for the nice presentation. I'm not familiar with the topic. When do you use the radioembolization? When the patient is not eligible for surgery? So is it a last line therapy or?
So, yeah, there is a defined eligibility criteria for that. So in first line, if the tumor is small, so it's less than 2 centimeters, we use ablation. When the tumor is bigger, we use, it's between 2 and 8 centimeters. We use radioembolization because these two therapeutic ways could be curative. So this is why we use that then. And if the tumor is bigger, then we use transarterial camel embolization, which is a palliative treatment option. So we try to cure the tumor first, and this is why we use radioembolization, if ablation is not possible.
Thank you.
In early stage tumors, of course.
Congrats on your presentation, really nice results. I'm not familiar with the radiology, and there was a word I didn't understand. What in the background, what does a SCOUT mean, and how is holmium better in that aspect?
Okay, thank you for your question. So SCOUT is a lower dose of holmium that we give to the patient a week before the actual radioembolization with the therapeutic dose of the isotope, so that we can calculate dosimetry and evaluate how much activity we need for the treatment.
Thank you very much.
Thank you.
Hi, congrats for your presentation. I have a question regarding your second topic. Which one is more expensive, holmium or yttrium?
Thank you for your question. Yeah, both microspheres are quite expensive, but they are exactly the same price. So
thank you.
These are not differ.
Thank you, Petra, for the amazing presentation. I was wondering whether you know anything about the patient experience during and after radioembolization with holmium isotopes.
So you mean the side effects and?
Yes, whether there are any common side effects.
Okay, thank you. So there is a syndrome called post-radioembolization syndrome, which includes fatigue, nausea, some abdominal pain, but it's less severe than the other local regional treatments. And it rarely needs hospitalization. So the radioembolization does not have that big side effects. Also, in the procedure, there could be some discomfort because of the arterial access and these kind of things.
Thank you. Sounds good.
Thank you.
Probably I'm staying too much in the operating room. Do you use radioembolization as a neoadjuvant therapy before operation to reduce the size of the tumor?
Well,
like in chemotherapy cases?
I don't think we do, but we use radioembolization for a bridging therapy to transplantation.
Uh-huh.
But I don't think we use it to neoadjuvant therapy.
But not before ablation, okay.
No.